These are the various vaccines we're going to go through, and let's go. So, which one of the following vaccines is a live vaccine? All right, let's stop right here. Good. Yay. All right, so why is it important to know what the live vaccines are? And here they are. And keep in mind that I don't expect you to get a question on the intranasal vaccine. It has not been used for the last 2 years, and it may be used a little bit this year. We'll talk about that in a second. But if you do get a question on the intranasal vaccine, it will be about the contraindications, and that is reactive airway disease and asthma. But I really don't think you will. And we'll talk a little bit about OPV. But the ones you need to keep in mind: MMR, varicella, the combination MMR-V vaccine, and rotavirus. And keep in mind that this is important because live vaccines are contraindicated in immunocompromised patients. There's always an exception, and the exception is to give the MMR and the varicella vaccines, not the combination vaccine, but the individual vaccines, to asymptomatic children with HIV. And what makes a child asymptomatic is defined there for you, and that's in regards to CD4 counts. But if you are described an HIV patient who's doing well and thriving, and it's due for these 2 live vaccines, then you can go ahead and give it. Okay, now give rotavirus vaccine to asymptomatic and HIV-infected infants, irrespective of the CD4 counts. And be sure to remember that live vaccines are not contraindicated if an older sibling, say, is immunocompromised, undergoing treatment for ALL, and if an individual within the household is pregnant. Okay? So let's look more closely at pertussis. Which one of the following may be associated with pertussis early in the course of the disease? All right, good. So leukocytosis characterized by lymphocytosis. And that can be a very, very significant leukocytosis. So there are 3 stages: the catarrhal stage, the paroxysmal stage, and the convalescent stage. Remember, it was mentioned in the ID talk that the period that is most contagious is the period that basically looks like a URI. And that's one of the reasons that pertussis continues to be seen today, because it is spread amongst a at-risk population prior to the time that the paroxysmal cough begins and the disease is recognized. The paroxysmal stage, remember, may not include a whoop in younger infants, and the presentation there is apnea. So 2-month-old with apnea, think pertussis, as well as RSV and some of the other etiologies. And then a very long convalescent period of time follows. Diphtheria caused the gray friable membranous pharyngitis is what to look for. Sometimes respiratory distress due to very significant cervical adenitis. And characteristically, this membrane can be peeled off. And then hopefully you'll never see tetanus, but this is what it might look like. As Dr. Bolton mentioned, a lot of these pictures are clearly old because thankfully the diseases are so rare at this point in time. So DTaP schedule, 3-dose series at 2, 4, and 6 months. 2 additional doses, but keep in mind that the 5th dose is not necessary if the 4th dose was administered after 4 years of age. So, which one of the following adverse events is a contraindication to subsequent vaccination with a pertussis-containing vaccine? Fever of 102, high-pitched crying for greater than 2 hours, encephalopathy within 7 days, seizure within 3 days, or persistent vomiting for at least 24 hours. A contraindication. Good. So encephalopathy within 7 days. So what are the absolute contraindications where your response should be don't give the DTaP? A history of an anaphylactic reaction, which is a contraindication to subsequent doses of all vaccine components, or, like the question mentioned, an encephalopathy that develops within a week following the vaccine. Finally, any evolving neurologic disorder. For example, a child with poorly controlled infantile spasms or other type of seizure disorder. A child is being evaluated for developmental delay, which is worsening. These are the 3 absolute contraindications where your answer should be do not give the vaccine. Now, there are other side effects that are defined for your boards as precautions. A precaution to any diphtheria or tetanus-containing vaccine is Guillain-Barré within the last 6 weeks, or an Arthus-type reaction to the vaccine. The precautions also include a moderate or severe acute illness at the time of vaccines, or a history of seizures. Just a history, that's a precaution, but not a contraindication. Other precautions that might kind of sound like contraindications are listed here, which is a significant increase in temp, hypotonic or hyporesponsive episode. I've seen that just once, but after a couple of minutes after the injection, the child became literally limp. Seizure within 72 hours, persistent crying, and swelling of the entire limb. Now, I think in the real world, some of these side effects may cause concern about giving a DTaP, and I think some choose not to give another DTaP, or parents choose not to give another DTaP. But for your boards, these are not contraindications to the subsequent use of DTaP vaccines. That's an important difference to keep in mind. Now, what happens if you do delay the DTaP? Let's say that you get a scenario where the child has infantile spasms and has not gotten any DTaP vaccines because of that. If you get a scenario where that child has been deferred for a year, then the next best step is to begin immunization with a DT series. Just immunizing with diphtheria and tetanus along the schedule that's outlined here. So you can wait a year, but you don't want to delay the DTaP any longer than a year, always explaining to parents that the risk of developing pertussis is higher because you're not using the pertussis component of the particular vaccine. How do you treat pertussis? Excuse me. After cough is established, there is little effect on the illness. That's why, again, treating the individual with pertussis is really more directed at preventing additional spread of the organism to close contacts. Treatment is with azithromycin. Here are the doses. The doses are dependent upon the age. And again, remember the potential association, especially in children under 2 weeks of age, with erythromycin and questionably azithromycin and the development of pyloric stenosis. We talked about that the other day when we were talking about the reason for oral treatment for chlamydia conjunctivitis. In regards to post-exposure prophylaxis, if you're asked about that, it's the same regimen that is outlined on the previous slide, and you have up to 3 weeks. So if the scenario describes exposure 10 days ago or 14 days ago, still recommend post-exposure prophylaxis for those patients. Who do you prophylax? All household contacts and children in daycare, regardless of immunization status, and other close contacts outside of child care and the household as listed here. So how many of you have taken post-exposure prophylaxis for pertussis? I know I have 2 or 3 times, and so it is the most common vaccine preventable disease that we still see. Now, what about adolescents and Tdap? Why did we add Tdap to replace the TD? That's because adolescents have waning vaccine immunity. Adolescents served as a reservoir of infection, and they brought that infection to children who were 2, 4, and 6 months of age. So I'm guessing, I know I have, and perhaps you have, treated what we thought was perhaps community-acquired pneumonia and actually treated patients with pertussis. And in the adolescent age group, the buzzword for pertussis on your boards is post-tussive vomiting. I cough so hard that it makes me throw up. Think pertussis with that particular scenario. So Tdap is administered in the hope of decreasing the reservoir of an infection among that population. Give it at 11 to 12 years of age, catch up at the first opportunity between 13 and 18 years of age, and keep this in mind that Tdap can be administered regardless of the interval since the last tetanus and diphtheria containing vaccine. So if they got a TD at 12 years of age for some reason and now they're 14, give them a Tdap. It is okay. It used to be that you had to wait 5 years, then it was 2 years, and now there's a recommendation not to wait at all. Also, keep in mind that if a child who is 7 has not yet been fully immunized with 5 doses of DTaP, you can give 1 dose of Tdap to that child as young as 7 years of age. That's off-label, but that is included in the Red Book, and I think that's fair game to be asked on your boards. So that's the one exception to using Tdap below 11 years of age. And Tdap, unfortunately, is not the best vaccine, and it really only provides moderate protection for 2 or 3 years. Which brings up the point about pregnancy. Because adults transmit pertussis to susceptible infants, and because the majority of infants contact pertussis from family members, especially their moms, and because infants who are under 12 months, and especially newborns and those under 6 months, are at significant risk, it's now recommended to administer a Tdap during each pregnancy, preferably between 27 and 36 weeks gestation. So this is the only exception to using multiple doses of Tdap during pregnancy and during each pregnancy, preferably during the last trimester, again in the hope of decreasing transmission to a newborn infant who is not going to be protected until he's at least received a primary series at 2, 4, and 6 months of DTaP. Now, also, the various adverse reactions that we listed for DTaP are not precautions or contraindications to Tdap. So my whole arm got swollen from here to here after my 5th dose of DTaP. Is that a contraindication to Tdap? No, nor are any of these as well. And on your boards, there's going to be a lot of questions about adverse effects, contraindications, and exceptions to rules when it comes to vaccines. All right, and Tdap is not contraindicated in individuals with stable seizure disorders. What about wound management? The easy thing to keep in mind is the key is if there are under 3 previous doses and the wound is dirty, that's the only time immune globulin is recommended. In all the other 5 scenarios, immunoglobulin is not recommended. So if you just memorize this one, less than 3, dirty, yes. Otherwise, the answer is to immunize, but not to use tetanus immune globulin. All right, measles. Highly contagious. Most of the time, susceptible individuals will develop it. You're contagious prior to and after the appearance of the rash, following an incubation period of a median of 13 days. And the prodrome consists of fever, malaise, and anorexia, followed by the typical 3 Cs, cough, coryza, and conjunctivitis. Again, as was mentioned prior to this lecture, it's from head to toe and usually resolves after 5 to 6 days. If you're asked about Koplik spots, this is what they look like. You rarely see them because they're gone by the time the rash breaks out. And the rash is typically described as confluent, somewhat papular, and begins in the head, moves down towards the toes. The conjunctivitis is significant, and the photophobia is significant as well. Significant enough that I remember when I had measles, and I'm really dating myself, my mom would open the door and say, "Put your pillow or your covers over your head, I'm going to turn the light on." And I just remember how bad my eyes felt from any light whatsoever. Now you're all wondering how I can even walk up these stairs since you know I had measles. All right, what are the complications? Certainly, if the cough persists or the fever persists, that's of concern. Common complications are here, and the more serious complications are here. I think the ones that you'll probably most likely be asked about are the respiratory complications of bronchial pneumonia and laryngotracheobronchitis. What about mumps? Lots of mumps in the newspaper over the last year or so. It's infectious 3 days before until 9 days after, with an incubation period median of around 16 to 18 days. And here's a good example when we were talking about parotitis in adolescents with bulimia. I mentioned that with parotid enlargement, the angle of the jaw will be obscured, and you can see that it's totally obscured here because of the parotid enlargement, whereas if this were a high anterior cervical lymph node, the angle of the jaw would be present on this particular picture. So the parotid swelling can last for about 10 days, and oftentimes you can see an erythematous and enlarged Stenson's duct when you examine the oropharynx. Complications, it's typically self-limited, but especially orchitis in postpubertal males is relatively common. Testicular pain at times can be severe, and it's usually unilateral. This might be in your differential of an acute testicular torsion, like we mentioned earlier this week. It is possible also in young post-pubertal females, but far less likely to complicate than in males. And neurologic complications are rare, but they can be significant. Rubella, low-grade fever, non-exudative conjunctivitis, no photophobia, and oftentimes the only other finding along with the rash, which does, like rubeola, begin in the head and move down, is the presence of posterior cervical, posterior auricular, and suboccipital lymph nodes. That lymphadenopathy is consistent with rubella, and it's also consistent with roseola, those two disorders. The rash, again, spreads caudally, but it is similar in distribution, but it does spread more rapidly and tend to be less confluent and less dark as compared to rubeola. There is also an enanthem, Forsheimer spots, that you might be asked about. They look very similar to soft palate petechiae that you would see in strep, but note there's no exudative pharyngitis. And note the other time you might be asked about soft palate petechiae on your boards, as we talked about earlier, self-induced vomiting and trauma during eating disorders. Complications, especially arthritis. And again, congenital rubella syndrome, like we've talked about before, along with the torch infections. Cataracts, so-called salt and pepper retinopathy. Varicella, majority of infections prior to 10 years before the vaccine, develop typically within 15 days of exposure, and the prodromal symptoms are listed here. Typically, the rash is pruritic, appears in successive crops over the day. The vesicles quickly become pustules, quickly become crusted, and the key in the description will be lesions in different stages. That's the buzzword for varicella. And most lesions crust and fall off within 1 to 2 weeks. Complications of varicella include congenital varicella. This is the most common other in the TORCH acronym, and there are widespread scarring with limb hypoplasia and some destruction because of the size of the scars. Now, the look-alike for this on your boards might be an amniotic band. But an amniotic band, basically everything distal to the amniotic band, let's say the band was here, would be either absent or very, very hypoplastic. And everything proximal to the amniotic band would be completely normal. In congenital varicella, what perhaps looks like an amniotic band is not, because the limb is also hypoplastic. So hypoplastic limbs, scarring, and microphthalmia are all consistent with congenital varicella. And again, this is the most common other in torch infections. Complications are listed here. I think the classic that you might be asked about is cerebellar ataxia. Child presents with new onset ataxia. The MRI and CT are completely normal. Has a few white blood cells in CSF. Which one of the following infections is most likely associated with his now diagnosed acute cerebellar ataxia? And that's going to be varicella. Okay, before we get on to this question, let me mention one other thing about varicella, because one of you all asked me about this a couple days ago. And that is, what would you do with the question that not mom got chickenpox at 18 weeks, but mom got chickenpox a day after she delivered, or 1 day before she delivered? Do you or do you not give baby acyclovir? And there's a window during which baby gets the infection but has not yet had the opportunity to get the antibodies, and therefore baby needs acyclovir. That window is 5 days before through 2 days after delivery. And sort of a neat way to remember that is if you spell out varicella and then you make the V a Roman numeral 5, and then you make the two L's a Roman numeral 2, there's your 5 and your 2. And that's how I remember that window during which time you should get acyclovir as well. So regarding the varicella vaccine, which one of these following statements is true? The rate of herpes zoster is higher among immunized individuals. Only one dose is recommended if first administered at or after 12 years of age. The vaccine should not be administered to a woman who is breastfeeding. Transmission of the vaccine-associated virus to close contacts is extraordinarily rare. Or post-immunization rashes are rare and well under 1%. Okay, so let's go through these. This is the correct answer. So the rates of herpes zoster are the same among immunized and non-immunized individuals who had natural infection. Over 12 years of age, 2 doses are still recommended. You have to wait 3 months between dose 1 and dose 2 if you're under 12, but wait only 1 month between dose 1 and dose 2 if you're over 12. Varicella vaccine is not contraindicated during breastfeeding. It is contraindicated during pregnancy because it's a live vaccine. And post-immunization varicella-like rashes occur in about 3 to 5% of recipients. The transmission of the vaccine virus is indeed extraordinarily uncommon. In the new Red Book, it describes 11 cases. And this is important because this is one of the reasons why the varicella vaccine is given to an immunocompromised household or a household with an individual who is pregnant, because the transmission of the vaccine virus is extraordinarily rare. And those who have become infected due to transmission of the vaccine virus have almost always had very severe eczema. And therefore, we're very susceptible, as they are to any herpes virus, when the skin is broken down. So we give this vaccine at 12 to 15 months, the second dose typically at 4 to 6 years of age, but you can give the MMR as close to 1 month apart. And again, you can give the varicella either 1 month or 3 months apart, depending upon the age of the child. Know also that if you do use the combination vaccine, so-called ProQuad, that it is associated with a higher risk of febrile seizures after the first dose. Therefore, the Academy does not have a preference between MMRV or MMR and monovalent varicella. And when the Academy doesn't have a preference, you won't get asked about it, okay? All right, mumps is problematic, especially recently. And in January of 2018, the AAP recommended that a third dose of MMR be administered to those who are at increased risk of mumps due to an outbreak, even if they have already received 2 MMRs. So this is a relatively new recommendation, probably too new to appear on your boards, but if it does, the answer is to give a third vaccine. Which one of the following represents a contraindication to the MMR vaccine? This could also be a contraindication to the varicella vaccine. And this centers around how much is too much when it comes to steroids. Someone who's using an inhaled corticosteroid, a child who's taking low dose every other day prednisone, a child who's completed a 5-day course of prednisone, a child who's completed a 21-day course of prednisone, or someone who's on a topical mid-potency corticosteroid for, let's say, eczema. Okay, so that's correct, and let's look at this a little bit more carefully. So high-dose steroids should be defined as greater than or equal to 2 milligrams per kilogram per day or 20 milligrams per day, whichever is less, for at least 14 days or more. In that scenario, the next best step answer is delay immunization for at least a month. Do not vaccinate during pregnancy. Do not vaccinate immunocompromised children, again with the exception of the stable and thriving HIV-positive child. Inhaled steroids, nasal steroids, topical steroids, low-dose oral steroids, every other day steroids, okay, and safe to proceed. Again, children of pregnant women can be immunized. The parents of a 15-month-old girl agree to the administration of only one vaccine at a time. Their daughter is given an MMR. What is the minimum time period that must elapse before the varicella vaccine is administered to this patient? Right. So this brings up the point of how long do you have to wait between the administration of live vaccines? You can give as many live vaccines on the same day as you would like, but otherwise you must space out live vaccines by at least 28 days. And this is becoming more important among populations of parents who are vaccine hesitant, and among some of I don't want to use the word recommended, but proposed alternate vaccine schedules that are out there. So at least a month between any two live vaccines, if not given at the same day. So again, okay to administer on the same day, separate by 28 days if not. And the reason for that is also keep in mind, and this, I think, scenario would be presented around a patient who was recently treated for Kawasaki's. Remember that live virus vaccines have diminished immunogenicity following receipt of immunoglobulin. So child comes in, discharged from the hospital last week, now stable on low-dose aspirin because of Kawasaki disease. How long do you have to wait to give a live vaccine? I doubt very much that you'll be asked, you have to wait 3 months for this, 6 months for this, 7 months for that. You won't be asked that. But you will be asked which particular vaccines you have to delay in a child treated with IVIG for ITP or Kawasaki's or anything like that. And these are the vaccines. Also, measles vaccine may suppress tuberculin reactivity. So you can, again, just like you can give the live vaccines the same day, you can administer TB skin testing and MMR on the same day, but if not, then you have to delay by 4 to 6 weeks before placing the PPD. And this scenario would likely show up on a question that involved the evaluation of an internationally adopted child who required extensive workup. We're going to talk a little bit about recommendations for children who have been adopted into the States in a little while. How about polio? The IPV vaccine given at 2, 4, 6 to 18 months and 4 to 6 years of age. Here are the contraindications. Wild polio does remain endemic in 3 countries, unfortunately. And much of the polio that is now being seen is not wild, but related to the vaccine. Remember, OPV is a live vaccine. The reason we no longer use it in the States is because on very rare occasions, either the child or a close contact contracted polio following vaccination. But OPV is still used in many parts of the world. Because of vaccine-associated disease, the trivalent has been replaced by the bivalent vaccine. But for those of you who may travel internationally on medical mission trips and the like, you may indeed see continued immunization with the OPV product. Again, it's shed in the feces, so fecal-oral contamination is possible, and it should certainly not be given to immunocompromised patients or to an immunocompromised household. That's the difference with OPV versus the other live vaccines. Whether you're still going to get a lingering question about this or not, I rather doubt it. Hib. Again, dating myself. This is not me, by the way. I'm not that old. But I still, does anybody even know what chloramphenicol is? Look at that, my goodness. Well, chloramphenicol is a nasty, nasty antibiotic with lots of side effects, but I still remember the dose of ampicillin and chloramphenicol for H-flu meningitis, and we would see 10, 15 children a year. It was just horrible. It was almost kind of a routine night, as terrible as that says, when we were on call to at least admit one child with Hib. Now it's only a rare cause of invasive disease. You're not going to, has anybody seen Hib here? Anybody? One person? So two people. And yet if that question was asked before the vaccine, all of you unfortunately would be raising both hands. So it's just not a very common bug anymore. There's the epiglottis. You can see the secretions. This explains why the child is so stridorous and short of breath, because that's the only airway that is left. Keep in mind that vaccines do not cover non-typable H-flu. That's why otitis and sinusitis has not been positively affected by this. It's either a 2 or 3 dose primary series with a booster at 12 to 15 months. One thing that you will not be asked about is the different types of vaccines available. This is only listed here for your information. Just know that it's a required vaccine in either a 2 or 3 dose primary series. Don't worry about the specific name brands. This is, however, a vaccine that requires fewer doses as the child grows older. So, for example, a 17-month-old child who has never been immunized only needs 1 dose. This is important to know, again, because you may have a vignette that talks about a child who was removed from his or her home due to medical neglect and now is 18 months old. How many Hib vaccines does that child need, for example? Or again, an internationally adopted child who is somewhat older. So both Hib and, like we'll talk about in a second, Prevnar, PCV13, require fewer doses as the child grows older. And for individuals older than 60 months, the only ones that need a Hib vaccine are those with an underlying immunosuppression or who are asplenic, either functionally or anatomically. In regards to chemoprophylaxis, it's important to remember that this may be a scenario that you are asked about. It is used to eradicate nasopharyngeal carriage, again with rifampin. It's recommended in close contacts, child care or preschool contacts, and at times the index patient. Who's a close contact? Here's the definition. And the household contacts should all be immunized, and basically the easy thing to remember is if they have not been completely immunized or there's an immunocompromised individual in the house. And chemoprophylaxis is indicated for all. And these are very common questions. The index patient, him or herself, may need to be prophylaxed if they were not treated with a third-generation cephalosporin. A caveat, this is different than meningococcal disease, is that chemoprophylaxis in childcare is not recommended unless there are at least 2 cases of invasive disease. All right, and if you are using rifampin, remember that it may interfere with the efficacy of many medications as listed here. What looks like epiglottitis, it's going to be on your boards perhaps. We've been through these. Peritonsillar abscess with deviation of the uvula away from the side of the abscess. Laryngotracheobronchitis due to parainfluenza. Retropharyngeal abscess. And finally, a foreign body. So someone comes in with stridor and is ill. Your differential diagnosis is these 3, along with Hib is 1 minute fine and the next minute stridorous. That's a foreign body. How do you tell the difference between these 3? Between peritonsillar abscess and retropharyngeal abscess? It will be on the exam. And with laryngotracheobronchitis, they're sick for 2 or 3 days before they present. With the abscesses, they're acutely ill within a period of hours. Hepatitis A vaccine, recommended in a 2-dose series. This is pretty straightforward and not associated with a lot of contraindications or adverse effects. Certainly, individuals at high risk should be targeted if they were not immunized at a younger age. All right, next question. The mother of a healthy term boy is positive for hepatitis B surface antigen. Which one of the following is the most appropriate treatment plan for her newborn in regards to administration of the Hep B vaccine and or hepatitis B immunoglobulin? Here are your choices. I'll give you a second. Good. Okay, so D is the correct answer. And let's run through this. H-big only needs to be given once and not also at 1 and 6 months of age. So how do we handle this? If mom's surface antigen status is negative, immunization prior to nursery discharge and preferably within the first 24 hours, followed by a second dose at 1 to 2 months and a third dose at 6 to 18 months. If mom is positive, then the birth dose must also be associated with H-big, and those should be given by 12 hours of age. And if you're using a combination vaccine that includes hepatitis B, that's perfectly okay, and it's perfectly okay that your patient gets a total of 4 rather than a total of 3 doses. So the important caveat, birth plus H-big in moms who are surface antigen positive. Now, again, these infants, you're going to want to ask the question, did this vaccine work? And therefore, it is recommended that only if mom is surface antigen positive, those infants be tested at 9 to 12 months of age to be sure that they have antibody and hopefully that they don't have antigen. If they do not have antibody, then you should either repeat the dose in a 3-dose series, or you can give 1 revaccination and repeat the testing. The older recommendation was just to go ahead and give a complete 3-dose series. A newer recommendation gave you the option to do this. But definitely the take-home message for your boards is remember how to treat a baby whose mom is surface antigen positive with both HBIG as well as the vaccine. Breastfeeding is okay as long as a mom does not have sores or areas of bleeding on her breasts. Otherwise, moms who are surface antigen positive may breastfeed. Now, there's a caveat for vaccine for hepatitis B in premature infants that you need to be aware of. Infants weighing less than 2 kgs, that's the buzzword, less than 2 kgs, need to be treated differently. If mom is positive, go ahead and treat as you would any child, but the caveat is that you cannot count the birth dose of HPV if that birth dose was given to an infant less than 2 kgs. So that's why it's important when you're reading this scenario in a potential vignette question to look at the birth weight and make sure that this particular caveat is not relevant. So don't count the birth dose. If mom is negative and the baby is less than 2 kgs, you should delay the birth dose to at 30 days of age or at hospital discharge, whatever is earlier. But you can count that birth dose as long as mom is surface antigen negative. So 2 important caveats for hepatitis B vaccine. Number 1, is mom surface antigen positive or negative? And number 2, what is the birth weight of the child that they're describing in your vignette? Now, if mom's status is unknown, obviously you want to determine her status as soon as possible. If that child's birth weight is under 2 kgs, go ahead and give the vaccine and the immunoglobulin as if she were positive. If they're over 2 kgs, then HBIG is not immediately indicated until the surface antigen status is known. So again, that 2 kg difference is important if mom's surface antigen status is unknown, just like it is if it's known. Pneumococcus. The dosing schedule, again, routinely, it's very similar to Hib, but again, like Hib, the number of required doses decreases as the child gets older. Remember also that some children will need the polysaccharide vaccine. Remember, Prevnar PCV is a conjugate vaccine. Conjugate vaccines work better in infants than do polysaccharide vaccines. However, for high-risk individuals, you're going to want to remember that after you have completed the course of pneumococcal conjugate vaccine, that you're also going to want to consider the use of polysaccharide vaccine. Who should get it? These individuals should receive the polysaccharide vaccine. Hemoglobinopathies, functional or anatomic asplenia, various immunodeficiencies, chronic renal disease, and those on corticosteroids. Additional high-risk individuals who should also get the vaccine are listed here. The difference between this group is that those that are starred require a single revaccination in 5 years. And basically remember that it's those who are in some way, shape, or form immunocompromised. I've seen, for some reason, the question about cochlear implants very frequently on various exams, so keep that in mind, that that particular group of children, because they have a foreign body close to the central nervous system, also need the polysaccharide vaccine. Keep in mind also that you want to complete the dosing of PCV13 prior to using the polysaccharide vaccine. Meningococcal vaccine, it contains serotypes A, C, W135 and Y. There are two types. This is one exception where you are going to need to know perhaps some differences between these types, and we'll talk about those. The meningococcal vaccine routine at 11 to 12 years with a booster at 16. Here is the catch-up schedule, which does push out that booster vaccine a little bit or eliminate the need for the booster in the first place. And certainly immunize your college freshmen if they have not been immunized previously with one dose. The buzzwords for meningococcal: boarding school, college freshman, military recruit, any situation that causes crowding. So that's the routine recommendations for meningococcal. Chemoprophylaxis. Here's the criteria on who to chemoprophylax. I think Dr. Bolton had a question about this. But again, as he mentioned, it needs to be with direct exposure to the patient's oral secretions, or in childcare, or in the household. And here's the bad news one: sitting on an airplane for more than 8 hours. I mean, it's bad enough to sit on an airplane for 8 hours, let alone sitting next to someone who has meningococcal disease. So fly home safely. Chemoprophylaxis with rifampin, same as with Hib in terms of the dose, but rather than over 4 days like it is with Hib, it's over 2 days with 2 doses a day. Who's at risk of meningococcal disease? Again, buzzword: complement component deficiency. In this patient who is now presented with his second episode of invasive meningococcal disease, which one of the following labs might you or should you check? It's going to be looking for complement deficiency. Again, like Hib, anatomic or functional asplenia. There are 3 bad actors when you don't have a spleen: pneumococcus, meningococcus, and Hib, all the encapsulated organisms. Those are the ones that are going to be at high risk. Those are the ones that are going to need pneumococcal vaccine and the polysaccharide vaccine as well. Again, for those of you who may be traveling, or for those of you who have patients who have traveled to and from these areas of the world, they may be at risk of meningococcal disease. All right, it gets a little trickier for those high-risk individuals in regards to how to use meningococcal vaccine. These recommendations are for those with asplenia. You can use this particular vaccine. There are the doses. Here are the doses if it's a little bit of an older child that you're presented with rather than an infant. But Menactra cannot be used in these individuals. And the reason for that is that Menactra may interfere with PCV13. And PCV13 is especially important in individuals with asplenia. So just keep this in mind. This is one of those exceptions where you might need to know the difference between the 2 vaccines. With a normal spleen, then it's okay to use Menactra, but again with the caveat that you have to have completed PCV13. But it's a little bit less of an issue with a normal spleen. Children who are at risk, who are between 2 and 10, need 2 doses, not 1, but 2. Children who are 11 and do their regular recommended 11-year-old vaccine, again, need 2 rather than 1, different. And then for those high-risk individuals, they all need boosters, even though they get an initial 2-dose series. So the scenarios around the immunocompromised individual do a meningococcal vaccine get somewhat complicated, and this hopefully will allow you to look through that. What about serogroup B? There is a vaccine that's recommended only to high-risk individuals. Again, we've been through who those are. It is optional at 16 to 23 years of age. And there are different vaccines that are listed there. I've only given this a couple of times, and it was in children, both of whom had sickle cell disease and were teenagers, because this vaccine has not been available for a very long time. Rotavirus, very common that children were infected by 5 years of age. Non-bloody diarrhea with vomiting preceding the diarrhea. That's a key to rotavirus. Remains a major problem in the developing world. So which one of the following represents a contraindication for the use of rotavirus vaccine? A history of rotavirus gastroenteritis, CF, a history of intussusception, trisomy 21, or treatment with IVIG within the previous 4 weeks. History of intussusception, correct. Now, this IVIG, that's MMR and varicella, it doesn't seem to be much of an issue with rotavirus. So there are 2 vaccines. You will not be asked to question which one of these is better because the AAP does not have a recommendation. And again, if there's no recommendation, you won't be asked. The minimum age is 6 weeks. The minimum interval, 4 weeks. Preferably, preterm infants should be stabilized, and be sure not to give the vaccine until after nursery discharge. Now, this is where it gets a little unusual. Very, very specific criteria. You cannot initiate the vaccine at 15 weeks or older. So 14 weeks, 6 days is literally the last age that you can give this vaccine. And you cannot continue the vaccine in anyone over 8 months, 0 days of age. The reason for that specificity is because this vaccine was purposely studied in an age group prior to the period of time where most children develop intussusception. Because an older rotavirus vaccine was removed from the market probably 10 plus years ago now, because that vaccine increased the risk of intussusception. So that's the reason why you should know these very specific criteria, which sound way too specific, but there is a reason behind that. The contraindications, the 2 are history of intussusception or of SCID, or a history of latex allergy, because one, not the other, of the vaccines does have natural rubber latex. Because this is a very specific difference between the 2 vaccines, you won't be asked about it, but you would be fairly asked about these 2. Precautions are listed here. Another immunocompromised state other than SCID, gastrointestinal illness or pre-existing intestinal tract illness, or again, spina bifida because of latex exposure. Know these 2, and I think you'll be fine. Influenza. 2 forms, the trivalent and quadrivalent killed vaccines or inactivated vaccines. The live attenuated influenza vaccine, the most recent recommendations are this: immunize with the inactivated vaccine, if at all possible. If the child is either going to get nothing or the live vaccine, then you can use the live vaccine. But by all means, it is much, much preferred to use the inactivated vaccine. And again, the live vaccine wasn't recommended at all over the last 2 years. On your boards, I really don't think the live attenuated vaccine is going to show up. Previously unimmunized children 6 months to 8 years of age need 2 doses, at least 4 weeks apart. What if a 5-year-old who is due 2 influenza vaccines only gets 1 vaccine? What do you do the following year? And the following year, that individual should get 2. Okay, so if they miss out on the opportunity to get 2 the first year, the second year rolls around, give them 2. If they only get 1 that year, then you can stop. And children over 9 only need 1 dose. So again, that's in the previously unimmunized population. First time they need 2 doses. The inactivated vaccine is especially important at those at high risk of influenza complications. Those who are at high risk include the younger age group, those on chronic salicylate therapy, those with underlying cardiopulmonary disease, those with underlying central nervous system disorders, renal disorders, endocrinopathies, hemoglobinopathies, and the like. All of these at increased risk of influenza. Contraindications are really very rare, with the exception of a history of a severe allergic reaction, and the precautions are listed here. Our institution and our school mandates influenza vaccine, and I got flu this year. And literally, I missed work for the first time in 31 years. I didn't. My kids thought I was gone. They said, "Dad didn't go to work? I mean, what's going on?" Literally, they all came over. It was like last rites for Dad. You know, I was kind of scared. I thought they knew something I didn't know. But I was out for 3 or 4 days, so it is nasty. So get your vaccine. Even though I got my vaccine, I still got it. Egg allergy. Give the vaccine if you're egg allergic. It is no longer a contraindication. Egg allergy does not impart an increased risk of anaphylactic reaction. The obvious caveat to that, as with any office, any vaccine, you want to be sure that you're prepared to deal with an unexpected anaphylactic event. So all children with egg allergy should receive the vaccine. Skin testing is not recommended, and skin testing with the vaccine is recommended only if a child has had a prior severe reaction to the vaccine, not a prior severe reaction to egg ingestion. Okay, an 18-year-old mom has a 6-week-old. She's breastfeeding her. She got 1 dose of HPV about a year ago, and she wants to have another vaccine. What do? Give her the vaccine. Give her the vaccine followed by a second one. Give her the vaccine during this visit, followed by 2 more. In other words, start the series over again. Give the vaccine only after she discontinues breastfeeding. And again, give the vaccine after she discontinues breastfeeding, followed by a second one. So how do you deal with an interrupted schedule of HPV vaccines, and can you or can you not give it when breastfeeding is occurring? Okay, so that's the correct answer. So she's going to need a total of 3 because she's over 15 years of age. You never have to start a vaccine over again. So a 4-year-old comes in and all the shots that he has ever had were 2 months of age. Do you have to start over again? The answer is no. You never have to start over again. So she needs a total of 3. She's had 1. So she can get a second during this visit, and then she'll finish up with a third. It's not contraindicated during breastfeeding. So we talked about the HPV vaccine when we did adolescent medicine, so I'm not going to go through it in any greater detail, except to remind you that the total number of vaccine doses depends upon the age at which the individual begins his or her vaccination series, routinely recommended at the 11 to 12-year-old visit. So Tdap, HPV, MCV is the 11 to 12-year-old group of shots. Catch-up vaccination, again, recommendations are a little bit different for women as compared to men. and in this case, the 22 to 26-year-old male age group, more selective immunization with the HPV vaccine like we talked about earlier. Vaccination series, really important to remember to begin it at 9 years of age in children who have been sexually abused. Also, you should begin it at 9 years of age in those who are immunocompromised. Don't wait until the routine 11 to 12-year-old. Not recommended during pregnancy, and pregnancy test is not recommended prior to vaccination. There's no evidence of harm, but obviously with the exception of flu vaccine, also with flu. With the exception of flu vaccine and Tdap, you're generally not going to want to immunize women who are pregnant. Immunizing with the flu vaccine is very important during pregnancy, along with Tdap. I mentioned this earlier, human papillomavirus respiratory papillomatosis acquired during vaginal delivery. You can see the lesions here. And again, this is the child who looks as if they have tracheomalacia, but the tracheomalacia gets worse over time as these HPV lesions continue to grow. So stridor, hoarse cry, et cetera. And these, unfortunately, are notoriously difficult to treat. They're treated with lasers, but oftentimes will recur very, very frequently. All right, to summarize, by 18 months of age, here are the immunizations you should have had. By 4 to 6 years of age, and by 11 to 12 years of age. We've been through all of these. Some high-yield notes to finish with. Again, never an indication to restart a series, with the ever-present exception being international adoptees because of the concern about the quality of the vaccines. The number of vaccines administered during one visit, there's no official upper limit. Oftentimes that unofficial upper limit is 4, giving 2 vaccines in each of the 2 lower extremities, but you can give more. Inactivated vaccines you can give on the same day or any day before or after other inactivated or live vaccines. However, with live vaccines, space them apart by 4 weeks if you don't give them on the same day. Vaccinate with a history of local reactions, mild illness, current antibiotic use, sick contacts, family history of seizures or an adverse reaction, and vaccinate during treatment. That's the key word, treatment of active tuberculosis. Do not vaccinate if there is any history of a previous anaphylactic reaction to a vaccine or to a vaccine component. In any patient who is moderately to severely ill, you probably don't want to give the immunization for a couple reasons. One, if the patient gets worse, you might blame it on the vaccine, and it might not be the vaccine's fault. And secondly, it may in some way interfere with the body's response to the infection. Now, what makes somebody moderately to severely ill? I think, toxic appearing, hospitalized, not a cold, not an otitis media or a strep pharyngitis, but pretty sick for that. Okay? Various antigens that are in vaccines. Again, most all the time you can proceed. So egg allergy, influenza and MMR can be given. Remember that neomycin is in IPV, but you should not proceed with vaccination if there is, for example, a serious local, even systemic reaction to a topical antibiotic, because they typically contain neomycin, and neomycin is also an MMR and varicella. Latex in some applicators and syringes, casein and gelatin, as you can see, but with the exception of a severe reaction to any of these, you can proceed with immunization. No evidence of harm from inactivated vaccines during pregnancy. Again, give Tdap as well as flu, but be sure to avoid any live vaccines. And as we've talked about, the importance of flu. And selective immunization of high-risk individuals during pregnancy is safe with these inactivated vaccines. But in general, the ones to remember for your boards are give flu and give Tdap. This is just for your information. The various combination vaccines are here. All right, so we'll finish up with common screening tests. One thing, there are, again, as I mentioned earlier, there are slides repeated in this section that are in other sections, so we're not going to go through those, but hopefully it's just going to make your review easier to have them in appropriate sections, and that's the reason for that. So we'll look at these and then we'll go. So recommended uniform screening panel is state dependent for newborn screening, but we've been through all of these conditions in a variety of talks this week, and just as a reminder that if you're evaluating a newborn, for example, for failure to thrive, one of the first things you want to do is look at his or her metabolic screen to make sure that there wasn't a positive finding that somehow got slipped by. Be sure to test prior to discharge. Collect blood samples on filter paper from a puncture wound and not before 24 hours, especially because that's unreliable for both PKU and hypothyroidism. So the recommendation is parents wanted to leave, 12 hours of age, they tested. Should you repeat the test? The answer is yes. All right, blood transfusions. Remember that makes the hemoglobinopathy screens unreliable. All right, the relatively new recommendations for screening for critical congenital heart defects you should know. Pulse oximetry is recommended after 24 hours of age and prior to discharge. Should be performed on both the right hand and either foot. And a pass is considered an O2 sat of greater than 95% in both the right hand and a foot, and less than a 3% difference between the right hand and a foot. Did not pass. O2 under 90%, O2 under 95% in both extremities on 3 consecutive measurements, or greater than a 3% difference in oxygen saturation between the right hand and the foot. Next best step, referral to cardiology for additional clinical assessment and echocardiogram. Which one of the following ocular findings best describes associated findings in an infant with congenital rubella? Good. Microphthalmia, congenital varicella, chorioretinitis, CMV and toxo, coloboma, charge syndrome, aniridia, Wilms tumor. So we talked about vision assessment in adolescents, 12, 15, and 18. Know also that vision assessment should be performed in the younger age group at these particular ages. How do you do so? In infancy, be sure to document the red reflex, observe for cataracts, corneal opacities, ptosis. I would add coloboma to that. Congenital cataracts are illustrated here. Retinoblastoma illustrated here with a sort of a whitish reflex. And ptosis, again, in the newborn period, most likely associated with Klumpke's palsy due to injury to C8 and T1 during a difficult delivery. Vision assessment, these are warning signs, so when should you refer an infant based upon your evaluation of his or her vision assessment? Here are the referrals and the various times. Again, 2-month-old who doesn't object track to 180 degrees, you don't need to refer, but you should if they don't track to midline, for example. Require is referred with all of these particular disorders. So if any of these are described in your vignette, the answer would be to refer. And then again, as they get a little bit older, if they can cooperate with the unilateral uncover test, that's probably the easiest one to do. And remember, a positive screen is movement in the uncovered eye when the other eye is uncovered. And that picks up the possibility of strabismus and therefore prompt referral for evaluation and treatment. So this is outside, obviously, of the infant age group. Visual acuity in a little bit older children can be performed with optotypes, especially those with various pictures. And this screens a variety of potential disorders that are outlined here. And again, new this year, and I mentioned this earlier, is the universal screening recommendation for amblyopia at 3, 4, and 5 years of age, because this is pretty common. It affects up to 5 or 6% of all children. And obviously, if you miss it, it can cause some significant problems. So the risk factors include, like we've talked about, strabismus, abnormalities of the eyes such as cataracts, positive family history, maternal substance abuse, etc. So new recommendation, screen at 3, 4, and 5 years of age according to Bright Futures. And then screening options are listed here, and we've discussed these previously. Vision assessment and referral. When should you refer these children? Probably the question that you're going to be asked about on your exam is when is visual acuity, when is referral indicated based upon the results of visual acuity? And they do differ in the toddler and young child age group, so I would suggest that you commit those to memory. And then also remember that a variety of inflammatory bowel diseases and collagen vascular diseases and rheumatologic disorders are associated with uveitis and chorioretinitis. So in any scenario describing these and other similar diseases, you're going to want to refer. In regards to hearing assessment, we talked about requirements in early, mid, and late adolescence previously. These are the recommendations in the younger age groups for risk assessment at every visit, and then more specific screening at these particular age groups. Because hearing loss is not all that uncommon, and because early detection and intervention improves language development significantly, neonatal hearing screens are universally recommended by the Academy, not targeted, but universal. I think in most cases, children are screened prior to discharge from the nursery, but the AAP does give a little leeway in their recommendation that it be done by 1 month of age, and the AAP does not have a recommendation in regards to the particular tests that should be used. Additional risk factors that, if you read in the vignette, should clue you in to the possibility of referral include a history of exposure to gentamicin, especially in the neonatal age group, neurodegenerative disorders, and various syndromes, especially craniofacial syndromes that are associated with hearing loss. This individual has Apert's syndrome. Any craniofacial syndrome associated with micrognathia, like Treacher-Collins and Pierre-Robin's, also associated with an increased risk of hearing loss. Know also Waardenburg syndrome, characterized by a white forelock and heterochromia. These individuals have a high risk of hearing loss, as do children with trisomy 21. And has been mentioned again, another board favorite is hearing loss and syncope, and that is prolonged QT syndrome. So keep that one in mind. How about blood pressure screening? Again, we've talked about this previously, and that the diagnosis should be confirmed on no less than 3 repeated and separate visits. And as I mentioned earlier, ambulatory blood pressure monitoring may be a very effective way to diagnose that, especially in those children who are particularly anxious. For children with no risk factors, blood pressure screening is recommended beginning at 3 years of age and annually. For children who are over 3 and at risk, blood pressure should be measured at every visit, and that's an important differentiation. For children who are under 3 years of age, they too should have their blood pressure measured at every visit if they are at increased risk. So who's at increased risk? Obviously, those who spent some time in the neonatal intensive care unit because of prematurity, those with congenital heart disease, recurrent UTIs, or any syndrome associated with GU abnormalities. So Prune belly syndrome or Eagle-Barrett syndrome might be an example. A male with posterior urethral valves, for example, and any family history of chronic renal disease as well. Remember that the term elevated blood pressure has replaced pre-hypertension. Here are the normal blood pressures for the age group that we are talking about now. BMI we've been through already, and again, this should begin at 2 years of age. This is an example of one of those slides that you've seen before that I just want to hopefully be organized in multiple places to help you study. Same with dyslipidemia. We've been through this before. The definitions of universal screening are reviewed again here, 9 and 11 and 17 and 21. Be sure to obtain 2 fasting lipid panels if these are the results of the universal screening. Also, remember that the results of those fasting lipid panels should prompt a difference in the answer to the question depending upon what they are. And if they're over 249, that's an immediate referral versus some of this intervention that would be appropriate if the average of the 2 falls into this LDL category. Now, for this particular age group that we're paying attention to this afternoon, again, the 2 to 8-year-olds should be screened if their family history is of any concern or if they themselves have risk factors. All right, so which one of the following blood tests is most likely to identify the cause of the radiologic findings that you see here? An ANA, an RPR, a CBC, a PTH, an ionized calcium, or a lead level? All right, good, lead level. So let's look a little bit more closely at the recommendations for lead screening. These are lead lines, typically associated with chronic lead poisoning. They're dense metaphyseal bands, or even denser than cortical bone. And you may see multiple bands indicating episodic exposure, and the places that you're going to see them are typically in the long bones. Recommendations for lead screening. The risk of exposure to lead is due to hand and mouth activity, crawling, being on the floor. So therefore, a verbal risk assessment is recommended by the Academy at these particular ages. And in addition, action should be taken, and we'll go through what these questions are in a second, if any response is positive or is unknown. However, screen for lead at 2 age groups, 12 and then again at 24 months of age. So who's at high risk? Those in communities where lots of housing is older, those in communities where there's a known lead hazard, lots of local construction, certain types of factories, those who are in homes that are recently renovated, those who may have been exposed again to soil or dust, or whose intake of iron and calcium is poor, and with a history of pica. Other high-risk household uses of various folk remedies that are listed here, and those who may have immigrated or have been adopted from countries such as South America, Central America, and Mexico, where there are higher lead levels. Also, there are certain household items that may contain lead, and then depending upon what parents' occupation might be, especially with stained glass making. It was actually the last case of lead poisoning I've seen was probably 3 or 4 years ago, and both parents were local artists and did a lot of work with stained glass. The diagnosis is tough because the symptoms are diverse and they're non-specific. And you can see cognitive impairment, language delay, lead intoxication is in your differential diagnosis of developmentally delayed children that you might pick up during surveillance and or screening. In the boards, it oftentimes is presented with new onset of seizures and a history of recurrent abdominal pain. If they're very, very nice to you, they might show you a flat plate that shows lead in the abdomen, but those are the two that typically appear on your boards. New onset seizures, and by history, some colicky abdominal pain, with the distractor for that being, for example, Shigella, because Shigella is associated with seizures and abdominal pain, but this will be described as chronic or recurrent rather than acute. Remember, there's no safe level of lead exposure. The threshold has decreased over time. It's now down to 5 micrograms per deciliter. But again, this is the intervention threshold, not the quote-unquote normal level. There is no normal lead level. Venous blood sampling is preferred for lead screening because capillary sampling tends to pick up lead from skin. So if you're given the choice of one versus the other, always choose venous blood sampling for that reason. And if you do get a capillary specimen, the next best step is not to intervene, but to get a venous blood sample prior to intervention. One of the more characteristics findings that you could be asked about is basophilic stippling. And again, it is associated with toxic injury to the bone marrow, which can be due to lead, but may be due to others as well, such as severe anemia or thalassemia. So which one of the following is a known risk factor for iron deficiency anemia? Let's move on to iron. In an 8-month-old. Lots of cow's milk early on, lots of juice, history of pyloric stenosis, chronic prophylaxis with TMP-SMX for management of reflux, or goat's milk feeding. Okay, and so it's definitely cow's milk. Cow's milk has very little iron in it, and the iron is not very bioavailable. Goat's milk is associated with B12 and folate deficiency. Goat's milk association with B12 and folate gives you a macrocytosis, whereas iron deficiency gives you a microcytosis. Juice intake associated with lots of GI symptoms and poor growth, no association between these two scenarios. So what defines anemia is somewhat dependent upon the age of the child that's presented in the vignette, and know that you are a little bit more aggressive with older individuals when compared to younger individuals when you look at the hemoglobin thresholds. Keep in mind that the MCV is typically decreased. Microcytic, microchromic anemia is consistent with iron deficiency, and increased blood cell distribution is consistent as well with iron deficient anemia. If they give you ferritin levels, sometimes ferritin is measured in an evaluation of anemia, and those are the levels. Again, they differ a little bit depending upon the age, but keep in mind that ferritin, like platelets, is an acute phase reactant. And sometimes ferritin is actually used to measure the possibility of inflammation and or especially inflammation, but sometimes neoplasm as sort of a poor man's screen for inflammation. Screening for anemia, be sure to review risk factors at multiple well-child visits and screen all infants at 9 to 12 months. So Medicaid oftentimes requires screening for anemia and screening for lead at both the 1 and the 2-year-old visits. Again, repeat testing, and in many states this is routine at around 2 years of age, and especially in the Medicaid population. You can see these cells are very small, they're very hypochromic. The vast majority here, this is perhaps a reticulocyte here, that's why it's got more hemoglobin, but the vast majority are both microcytic and hypochromic. High-risk infants should be screened more frequently because of all the factors that are listed there. And also, there should be no use of low iron formula. It's not even available in the majority of places. And early cow's milk feeding will be associated with iron deficiency anemia. In the preschool age group, and then again in the older age group, it's all targeted screening based upon your risk assessment. Poverty, low iron, chronic disease, malabsorption, heavy menses, etc. So lead, basically 1 and 2. Iron deficiency in most places 1 and 2 as well. Otherwise, screening should be based upon your assessment of risk of lead intoxication and of iron deficiency anemia. Urine screening is easy, don't do it. Tuberculin screening, who should we assess? 1 month, 6, 12, and 24 months, and then annually. Again, assessment. Targeted based on recognition of risk factors. What are those risk factors? Who should you, on your boards, answer yes to evaluating for tuberculosis? Immigrants from countries with endemic infection or travel to those countries, they're listed there. Contact with an individual with contagious TB, radiographic or clinical findings, prior to immunosuppressive therapy, that's a common one. And then in HIV-infected individuals. I would add to that risk factor visiting individuals who are incarcerated. We looked at this slide before. Again, it's just included for your reference in regards to what makes a TST positive. And as been mentioned several times, BCG should not alter the interpretation of a TST. As I think I mentioned before, with interferon gamma release assays, the Academy has very recently changed this from 5 now down to 2. So when I made this, it was some data support the use in younger children. The Academy has now made the recommendation that in any child receiving a BCG vaccine who is 2 years of age and older, the preferred testing is with an IgRA and not with a tuberculin skin test. So this due to that recent recommendation, changes to 2. Now, what about children that you might be taking care of who have immigrated to this country or who have been adopted from another country? The Academy has put out more and more recommendations about caring for this group of children in recognition of the fact that the number of children from these categories continues to increase. And if these children get any screening in their home countries, it's going to be very limited to 1 or more of these particular illnesses. So suffice it to say that their health care has probably been very limited at best, and suffice it to say that if they do come with records, they're going to be pretty brief. Also, these particular tests are oftentimes performed months before arrival. So even if there's evidence of testing for these diseases, the AAP recommends that these children be retested for all of them. Once they get in the U.S., how do you evaluate these children? Well, obviously, you evaluate their nutritional status for any evidence of congenital anomalies, especially from those from the former Soviet Union. Evaluate for fetal alcohol spectrum disorder, vision and hearing, developmental status, and oral health. BCG vaccine is probably going to look like this, just a little bit of a scar. And obviously for any skin infestations, and be careful to evaluate them for evidence of a hepatosplenomegaly, which could be consistent with a parasitic infection, with sickle cell disease, depending upon their age. Remember, most children with sickle cell will auto-infarct their spleen by around 4 years of age, and chronic malaria will also cause hepatosplenomegaly. The exam for physical and or sexual abuse, unfortunately, needs to be performed as well. All of children in this situation should be evaluated for anemia, for hemoglobinopathies, and for iron deficiency. They should also be evaluated for infections. And remember that eosinophilia may be an indication that they have an underlying parasitic infection. Serum lead levels are recommended, as are G6PD assays, hemoglobin electrophoresis, like I mentioned before, and thyroid function testing. So it's a pretty complete, let's start from the beginning evaluation that's recommended by the AAP. Stool for ova and parasites is also recommended to include Giardia and Cryptosporidium species. And again, if eosinophilia is present on your CBC and negative stool and oviparasite and are first found, additional serologic screening, especially if they are from parts of Africa and Southeast Asia, is recommended for Strongyloides and for Schistosoma species. Children from areas with high prevalence of certain parasites also need specific testing. So there's a great website on the AAP that will help you through this. For your boards, I would be familiar with the recommended testing. I would be familiar with the recommended testing to include stool. I would not worry about them getting so specific that you have to remember these various things. And obviously, test appropriately if there is evidence of sexual abuse. Evaluation is also recommended for all children for hepatitis B, for hepatitis C, for syphilis, and for HIV. So again, it's a very complete evaluation. And in general, as for the reasons we talked about, the majority will probably be tested with IgRA for tuberculosis. One other comment about internationally adopted children, their immunization records, if they come with them, are oftentimes incomplete, oftentimes unreliable, and may oftentimes indicate use of vaccines which in reality were either expired or inadequate. So most recommend this is the exception to never start over again. Most recommend starting all over again in those who are adopted, with the exception if you choose, for example, to check a varicella titer or a rubella titer before giving the MMR or varicella, that's certainly acceptable. I think that is really up to you and should be considered from a cost benefit as well. Kind of a whirlwind of other topics, and we'll finish, that you might show up on your boards real quick, but there's several of them. So which one of the following best describes current recommendations for routine dental care in infants and children? Fluoride supplementation by 3, fluoride-containing toothpaste only in those at risk, a dental home by 4 years of age, fluoride-containing toothpaste for all. Sounds like a political statement. Fluoride-containing toothpaste for all. And fluoride-containing toothpaste not recommended in children under 3. Okay, so correct. So let's go through the current recommendations for fluoride. A dental home, ideally no later than 6 months after the first tooth erupts or 12 months of age. That's your board answer. Again, that's not necessarily real world, but for your boards, those are the recommendations, and for your boards, high risk, preferably by 6 months of age. So who's at high risk? Here are the individuals, and a lot of it has to do with either their medical history, especially NICU, or family history, or evidence on physical exam early on of increased risk of childhood caries. High risk also includes prolonged breast or bottle feeding, especially children who take a bottle at night or sleep next to mom and breastfeed at will throughout the night. And you can see the damage. I'm sure all of you have seen so-called milk bottle caries in children who may meet these particular criteria. Fluoride toothpaste recommendations. All children should have their teeth brushed twice a day with small amounts of fluoride-containing toothpaste, regardless of caries risk. What makes small, small? Here are the recommendations from the Academy. In regards to fluoride varnish and rinse, the Academy now recommends that all children every 3 to 6 months receive fluoride varnish either from general pediatricians and or at their dental home. And fluoride rinse is recommended, the OTC fluoride rinse now recommended starting at 6 in children who have a high caries risk. So all children, and then continued for those at increased risk. Optimal water fluoridation is 0.7 parts per million. So here are the recommendations for fluoride supplementation. Keep in mind when teeth develop, and for your boards, if no teeth within 6 months of target, that's the time to refer. So 6-month leeway and then refer. How about dental care and thumb sucking? The thing to remember about that is that because it can lead to the potential of dental problems, referral by 4 years of age is the current recommendation. And obviously the vast majority of children will outgrow that. And at least in my experience, the majority who continue to suck their thumb older than this have oftentimes always been very anxious children, or children who have been through difficult home situations or personal situations. But boards refer by 4. Important issues to address during well child care. You're familiar with all of these. One thing that you will probably get asked about is when to begin drug and counseling and sexual activity counseling. We'll be talking more about drug abuse tomorrow. Which one of the following is the most common cause of mortality in infants less than a year of age? So we had a question like this in the adolescent age group. What is it in those who are under 1 year of age? And congenital anomalies is correct. And so if you look at the AAP recommendations, obviously prevention is always important to discuss, be it anywhere from the temperature on your water heater to car seats to prevention of shaken baby syndrome, et cetera. Always include a focus on car safety for obvious reasons, and the list is here in case you're asked, and it moves right up into unintentional injury starting at 1 year of age. And this was the most common among the adolescent group. It remains most common throughout childhood into adolescence. So be sure to keep that in mind in case you were to be asked. The recommendations for the AAP in terms of car restraint, I think you're probably very familiar with. Just to be sure, rear facing until 2, may delay beyond 2 until the child outgrows the weight or the height limit. They do differ a little bit from car seats to car seats. Forward facing with a harness once they reach 2 years of age. And then belt positioning with a booster seat until around 4 feet 9 inches or 8 to 12 years of age. All children under 13 in the back seat. Screen time, new recommendations from the Academy. Avoid all screen media except video chatting. I don't even know what video chatting is, but I know you all do. So maybe you can teach me. But anyway, avoid screen media. 18 to 24 months, high quality program. So I would say PBS, Sesame Street, and the like. Parents should watch with children. 2 to 5, there's some grumbling out there. 2 to 5 years of age, less than an hour, again, of high quality programming. When you go out to dinner and you see a family sitting there and everyone's on their screens, maybe they're watching high quality programming while they're waiting for their meals to come. And then greater than 6 years of age, here are the most recent recommendations. So the big changes from the AAP are in the age group under 6 years of age. So again, for your boards, these would be important because when you're asked about anticipatory guidance, it's going to want to be along those lines. All right, additional screening recommendations. We've done it all. This was in the adolescent medicine and sexual health lecture. Thanks very much for all your attention.